Good afternoon. Welcome to Samaritans Purse International Health Forum. We're so glad you've joined us today. We hope you participate in our conversation today. For those of you that are joining us for the first time, you can chat with us in the group chat box on the right-hand side of your video screen. And we hope that you do post your questions and comments in there, and we will certainly engage with those and address those. Today's speaker is Dr. Natalie McDermott, and we're excited to have her here. She's coming to us from the UK, and her topic is to respond or not to respond, assessing when and what type of medical intervention is appropriate in disaster and humanitarian emergencies. She's had a lot of experience with Samaritans Purse, going out on disasters, and we're excited for her topic. So we'll introduce her in a minute, but before we start, I want to open us with a word of prayer. So if you'll bow your heads with me, and we'll ask the Lord to bless this time together. Father God, thank you for this opportunity to come together to learn and be with Dr. McDermott. Lord, I just pray that you give her the words to say as she shares with us, and Lord, may this be a time that we can grow in our understanding of when to respond to disasters and how to respond to them, and that you just give us wisdom. Bless our conversation today. We thank you for this time together. Amen. I'd like to introduce you to Dr. McDermott. She's a pediatric doctor undertaking a fellowship in pediatric infectious diseases. She is currently researching genetic susceptibility to infection with an outcome from the Ebola virus infection, and is based in Sierra Leone. As a member of the Samaritans Purse Medical Disaster Assistance Response Team, Dr. McDermott has responded to several humanitarian crises since 2011, and most notably the Ebola epidemic in Liberia. So without any further ado, Dr. McDermott, we'll let you begin your presentation.
Thank you, Beth, and hello to the audience. It's good to be with you today. I hope that you will enjoy this talk. I think it's quite pertinent, particularly for Samaritans Purse and the disaster response that we do on a very frequent basis throughout the world. So I hope everyone enjoys it. So as Beth said, I wanted to talk about assessing how you would undertake a medical intervention in a humanitarian emergency situation, and what type of medical intervention that you would want to develop. So the learning objectives really are to understand how to assess a humanitarian situation or emergency and the appropriateness of a medical intervention in that circumstance. To develop a strategy for assessing the type of medical intervention that may be appropriate in humanitarian emergencies, and then also to evaluate when it may be appropriate not to intervene with a medical intervention in a humanitarian emergency. I think we need to start by defining what constitutes a humanitarian emergency. Now, there are many different definitions, but the Humanitarian Coalition from Canada, which is a group of NGOs in Canada, have come up with a definition which is generally meets the remit of pretty much what every organization would consider a humanitarian emergency. And they define it as an event or series of events that represents a critical threat to the health, safety, security, or well-being of a community or other large group of people, usually over a wide area. The Interagency Standing Committee is a group of organizations and also United Nations agencies who came together in 1992 as a committee to try and improve humanitarian response, and also to try and improve the coordination of humanitarian response. And they've taken the definition a little bit further to define a complex humanitarian emergency. And they define that as a humanitarian crisis in a country, region, or society where there is total or considerable breakdown of authority resulting from internal or external conflict, and which requires an international response that goes beyond the mandate or capacity of any single and/or ongoing UN country program. So that's where the UN would not simply be able to step up their ongoing work in the country. They would require other actors to be involved to support the work that they're doing, or to take on a new role and responsibility to meet the needs of the population affected. So in terms of a strategy for assessing the situation, you really have two components to that. The first of which is, what is the actual situation in the country and who is affected? But then the other component is, what is the capacity of the organization that I'm working for? What capacity do they have to respond? So we'll start with the first section of who is affected. So we want to determine several things. First of all, we want to understand what the health needs are of the affected population. We want to make sure that whatever their need is, that's what we're targeting. We're not introducing some intervention that actually is not one of their needs, or is not a desperate need of theirs right at that point in time. So we want to make sure our response is targeted to the specific population affected and their needs. We also want to understand what health services are already available in that target region. And that's really going to depend on the circumstance that's occurred. So if it is an earthquake or a natural disaster, it may have significantly impacted health services that were already available in the country, so they can't function. But it might also be that we're responding to a nation that never really had robust health services in place in the first place, and something such as a conflict has reduced access to what services were in place. And so it may be that there really are no health services available. Alternately, it may be a country that already had very robust health services in place, and the disaster or circumstance that has occurred has not actually impacted those health services, and they may well have very good local capacity on the ground to respond to the need. The other section is who are the other actors involved. So it's not just what can our organization respond to, but what is already being done by other non-governmental agencies or the United Nations or local actors to meet that need. And then following on from that, who is coordinating that response? So is there an organization or a body coordinating all of the people involved in trying to provide a health response to a humanitarian emergency? And if there is coordination happening, how effectively is that happening? So then on to the other section, which is what capacity does our organization have to respond? So the question is there a need that is not being met by any other actors or local services that we as an organization can meet? Then what form could our response take? So that's based on our initial assessments of who are the target population and what are their needs. That's really going to dictate what form our response takes. But also what other actors are doing will also alter that, because if the need is already met by other actors, then it might be that we have a response that takes a very niche area or a very specific area to respond to, because the needs of the population are being met by other actors. And then the very final question is, what is our end game? So at what point are we going to say our intervention is no longer required? We should never enter into a response without knowing at what point we would be happy removing our intervention from the situation, because otherwise the response could go on endlessly, and that then impacts on our capacity as an organization to respond both financially and logistically. So let's take a look at, first of all, what the situation is. So as I mentioned before, there can be many different circumstances that result in a humanitarian emergency. So the first picture is following the earthquake in Nepal. And so a natural disaster is a very common one when we think of a humanitarian emergency, whether that's an earthquake, a typhoon, a tsunami, whatever that constitutes. And that will often significantly damage health services in the local area, as well as resulting in multiple different health needs of a population, from trauma through to risk of infectious diseases and so on. The next picture along to the right is actually the people of Borno State in northern Nigeria. So this is a circumstance in a nation which in the south of the country actually has a relatively good health service, but as you go further north, health services are much weaker. But these health services are now being cut off by Boko Haram. So supplies cannot get into the country, into that region of the country. Healthcare and access to healthcare is generally limited to the population, but also trade is not occurring in that region of the country. And so people are facing food insecurity as well. So there's an increasing need of malnutrition in children and also in the adult population, which is also resulting in an increased disease burden. Then below, we could talk about epidemics. So an epidemic is a very unique situation because it is largely requiring a healthcare or medical response. It doesn't necessarily require other components such as that we often see in emergency responses, such as food provisions, shelter provision, and so on. But when we talk about epidemics, we could talk about the Ebola epidemic, which severely incapacitated 3 countries' ability to function and impacted them heavily economically, as well as trying to control the epidemic. And also we can look at epidemics like Zika virus, which maybe doesn't necessarily require the kind of healthcare response we often think of, like a treatment facility, but it might involve monitoring of circumstances and supporting affected populations in different ways with their health needs. The next picture along is a picture of the European refugee crisis, which I will go into in quite a lot more detail towards the end of this presentation. But this is a very different population again, and it's been a very complex humanitarian emergency because of the different stages of the emergency and how the changes within European borders and laws and controlling populations moving has altered the health needs of the population over the period of time that this crisis has been ongoing. Then in the bottom left-hand corner, we can see a conflict situation. So this is actually a picture of the conflict in Syria. And that obviously has, again, different implications. So we know that due to conflict, there may be trauma situations occurring from explosive devices and gunshot wounds. But also, as we see in Syria, we see health facilities being bombed. So that's reducing the ability of the previously fairly robust health system of Syria to respond. And it's also preventing people accessing treatments and therapies because areas of Syria have been cut off and medical supplies cannot get in and humanitarian workers cannot get in also. And then the last picture is simply a camp situation. So that is a very large refugee camp. And that again has very different implications for the health needs of that population, which might be simply basic medical care at that point in time, but it may also be nutritional support. It may be a site where epidemics occur, where we see measles epidemics and a vaccination campaign is required, and so on. So there's many different components to the kind of response we can see and the kind of intervention we might want to apply. So let's talk about who might be affected by a humanitarian emergency. And the first picture is really just to say that in many emergencies, the entire population is affected. So that's not just the young or the old, but it could be young and middle-aged adults as well, particularly in conflict situations, that might be the case. But even in epidemic situations like the Ebola epidemic, actually a very large number of people infected were actually the young to middle-aged adult population rather than the very young and the very old, even though the very young and the very old had much higher mortality rates. In certain circumstances, it may just be the young that are affected, so it may be infants and children. So when food security is an issue, and access to food is a problem, it is often young children and infants who will suffer the most initially. That's not to say the adult population won't also suffer, but often the children and infants are very vulnerable. They're very vulnerable to malnutrition, and then they subsequently succumb to infectious diseases as well. We also know that the elderly population are a very vulnerable population as well. Traditionally, they don't necessarily get a big focus in humanitarian emergencies and response, but they may well be a missed population that need to be targeted, especially if there has been the removal of basic health services in the country and they cannot access medication for chronic medical conditions they may have. And then we also have pregnant women who may also be disproportionately affected by certain circumstances, particularly if the health service has been damaged and there are no maternity services available for them to access. Or in the case of the Zika virus epidemic, we know that actually pregnant women are the the most at risk when it comes to there being consequences of Zika virus infection. So these are the main groups we can talk about, but each emergency is different, and that's why an assessment is required to determine who exactly is our target population in this circumstance. So then, as I mentioned before, we need to identify what the health needs of the affected population are. So it may well be a conflict situation or a natural disaster where the bulk of the response is, or at least the initial response, is trauma, and we require trauma surgeons and general surgeons and some kind of field hospital if a hospital isn't available because it's been damaged or it's not got access to, or the people don't have access to its services. But that's a very specific need there for trauma surgeons, anaesthetists, and so on. As a situation like that progresses, though, we may also then see infectious disease epidemics breaking out. We may see malnutrition, depending on how good the food aid has been or what the circumstances are, and if the population has been cut off from access to food. So our intervention may develop as the response or as the emergency develops in itself, and we identify new needs. The right-hand side top picture is a picture of the Samaritans Purse Cholera Treatment Center in the Cité Soleil in Haiti. And that's just talking about, again, about epidemics. And maybe in that circumstance, we need infectious disease experts, but we also need general physicians and pediatricians to address the medical needs of the population. In the bottom left-hand corner, that's a picture from the European refugee crisis from one of the camps on Lesbos Island in Greece. And that's where the population at the time generally just needed basic first aid and guidance about where to access treatment. So again, that's a very different response, and it also requires a completely different capacity of response in terms of what's needed equipment-wise in country and so on. And I will go into that further a bit later on. And then lastly, the other picture is what happens to people when access to medical care and access to food is cut off, and we start to see malnutrition in infants, and we start to see increasing levels of infectious diseases, and we might see disease outbreaks that require vaccination campaigns. But also, we might see an ongoing burden of chronic ill health in the adult population, which is being unmet as medical facilities do not have access to the treatments that are required. So what health services are available in the target country or region? And that really depends on what was there initially in that country or region, and then what's there now post a potential disaster or conflict situation. So I've just put here 4 different examples, which I've already mentioned to some degree. But if we look at the European refugee crisis, that was a very unique situation where we have a very large number of people entering a developed nation with a robust health service. So Greece has a very good health service. It actually has a national health service, which meant that access to healthcare for refugees was free at the point of use. So they didn't have to pay for it. And this, therefore, takes on a whole new realm of what is required from an international aid organization in terms of responding to health needs, because actually there are hospitals, there are primary healthcare centers where people can access treatment. But it may be that those facilities are overwhelmed by the sudden increase in the number of people, but they have access to the treatment is required and all the facilities that might be needed to treat a population. So that's one example. And obviously, with the European refugee crisis, Greece, much as it was suffering from a difficult financial situation at the time, it hadn't been subject to any kind of natural disaster, which might have damaged healthcare facilities or cut off their access to supplies. Then we can look at Syria. So Syria, prior to about 5 years ago, actually had a very good health service in place. It's unfortunately been significantly damaged by the ongoing conflict in the country for 2 reasons. One is that many of the health facilities have been cut off, so they can't access adequate medications and equipment. Two, many of the healthcare workers have been killed or have fled the country, and international healthcare workers find it very difficult to get in there right now. So there is a reduction in the number of healthcare professionals that can serve the population. But then three, many of the facilities have actually recently been bombed, either by the Syrian regime or by rebel groups. And this has resulted then in a disintegration of what other healthcare service was there previously. So actually there's a very dire need for healthcare in Syria at the moment, but that's off the back of them actually having a very robust healthcare situation only 5 years ago. And then we can look at South Sudan. South Sudan is a country that has ongoing conflict, but never really had a healthcare service in place in the first place. So even prior to the most recent conflict situation in South Sudan, there was really no significant health service in place. And what was present was being run by international organizations already. So again, that's very different from Greece and very different from Syria. There's also very few healthcare professionals or local healthcare professionals in South Sudan. So many of them are international healthcare workers who have gone to respond to the situation. And then we have the circumstance in northern Nigeria, where basic healthcare provision was in place in Borno State previously, although was probably relatively limited, but it was present. But due to the circumstances surrounding the Boko Haram infiltration of the area, it is now very difficult for medication and supplies to reach those healthcare facilities. Many of the healthcare workers have fled the area due to the risk of terrorist attacks. And so there's a reduction in the population that can deliver health services. And then we have an increasing need in that population because they've been cut off from healthcare now for quite a long time, but also from food. And so there's a severe nutrition crisis going on in country where many children have severe malnutrition. An MSF report recently for northern Nigeria, or for Borno State particularly, stated that there were very few children under the age of 5 visible. So the normal numbers of toddlers that we would see and infants just weren't there. And that is because many of them have died as a result of infectious diseases or severe acute malnutrition. What capacity does our organization have to respond? That takes on a different element now. So we need to consider financially, what is the financial capacity of the organization to respond? And that will dictate to us what the length of the response could be, but also how specific our response is. Even if we have limited finances available, it doesn't mean we cannot deliver some form of health response. It just means that we may not be able to deliver the full response that we would like. And in those circumstances, you might pick a specific area to respond to that is within the remit of your organization's capacities. One of the other elements to consider is what logistics do we have available within our organization, and what logistics are required of the intervention that we want to undertake. So what equipment is required for our intervention? Is it equipment that is available in the local country or area of the country that's been affected? Or is it equipment that we're going to have to bring in internationally? And if that's the case, where can we source it and how will we bring it into country? Is there a functioning airport? Will it require a helicopter to bring it in? Or could it be driven in trucks? And this will all depend on the circumstances that have affected that region. We also want to consider, will the equipment require a consistent electricity or water supply? Because if you're in an area that has been affected by a natural disaster or a conflict situation, it may well be that these are not available. And then we need to start considering bringing in a generator to run the equipment and also to pump water, and how we're going to get access to a consistent water supply. And these all have significant impacts, again, on an organization's financial ability to respond. And then we need to consider what kind of staff or volunteers or healthcare workers would be required to undertake the intervention. So we need to consider, do we need international medical staff for this, or can we hire national medical staff who are available to support this response? And also, what kind of other staff are we going to require in country? Will we require logisticians? Will we require staff who might be undertaking shelter and food distributions and so on? So we need to consider all components that might make up our response. And then we need to consider how frequently we need to rotate our staff versus the anticipated length of the response. So if we think we're only going to respond to a circumstance for 1 month until a country has been able to address the immediate needs of the disaster, and then their capacity to respond is restored, then it might be we only need a few staff because we don't have to rotate them very often. But if our response is going to turn into a 6 or 9 month endeavour, or maybe even longer, then we need to consider how many staff and how many volunteers we're going to require, and how often we're going to rotate through them to give them adequate rest time, but also we may have volunteers who can only respond for a specific period of time as well, as they have jobs that they must return to. So these are all factors that we need to take into consideration when we're thinking about the way we can respond to a situation. So we also want to look at who are the other actors providing a medical response. I've listed a few of the more major medical responders here. The ones that most people are probably familiar with would be Médecins Sans Frontières, the International Medical Corps, so IMC, and Médecins du Monde, or Doctors of the World. They're the three of the big ones, aside from ourselves, Samaritans Purse, at the moment. But there are other organisations who do health response. This may normally be more from a development perspective rather than an emergency situation. But Alima and Gol and Waha all stepped up when it came to the Ebola epidemic and actually ran treatment facilities in Sierra Leone and Liberia and Guinea. So there are other organisations involved, and there are others that I haven't even mentioned here. But it's just being aware of who the actors are providing that medical response in country, and whether we're going to partner with them, work alongside them, or just coordinate with them, and how that's going to work. And also, are the World Health Organization involved? And if they are, in what capacity are they involved? So then we would want to look at whether a coordinated response is ongoing. So the United Nations in 1991 was working on a system to improve coordination of humanitarian aid. So there was the development of the Office for the Coordination of Humanitarian Aid, otherwise known as UN OCHA, and they were developed. And in about 2005, they decided that coordination, that there were so many non-governmental organizations and international organizations involved, as well as United Nations organizations, that they really needed to have what they've called a cluster system in place to improve the coordination of humanitarian aid and ensure that it's being distributed throughout the region it needs to be distributed to, and that the population needs are being met. Now, when the cluster system was developed, and you can see it on the picture on the slide, there were different organizations who were made responsible for different clusters. The World Health Organization was made responsible for the health cluster. Now, we can move on to the next slide, please, Beth. The World Health Organization may be responsible for the health cluster, but that does not necessarily mean it is always the health cluster lead. So if you are responding in a situation where there is a national government health department who is functioning at an adequate standard despite the circumstances, then it is actually that government health department who are the health cluster lead, unless they specifically request that the World Health Organization take on the health cluster lead. So the UN and the World Health Organization will not get in the way of a sovereign government. And if the government has the capacity to respond, it is up to the government actually to coordinate all of the clusters if they want to, or to request the assistance of the United Nations to coordinate those clusters. And the United Nations may well support the government departments in the coordination of those clusters, but it is the government at the end of the day that has the right to make a decision of how the response is going to unfold. So how well the health cluster is being coordinated has a very significant impact on how you as an organization might respond to a situation. And its implications are, I've put under 3 different headings here, but one of them is the region that, as an organization, you might target. You wouldn't want to be replicating a response that another actor is already providing in exactly the same area. Not only would it not go down well with the other actor because it would be seen as encroaching on their territory, but also you would be providing a duplicated response in a region where there may be another region of the country that is also affected, and actually no actor is present in that location. So health cluster coordination is important to ensure that the aid that is coming into the country is equally distributed to the affected population. It also might dictate the service you may be able to provide. It will hopefully prevent you from providing an unnecessary service or duplicating a service that another actor is providing. But it also will hopefully ensure that we don't fail to provide an essential service in a location that has not received any aid from another actor, or where an essential service has not been identified as being missing. So that the health cluster is there to identify the needs of the population as well, and to ensure the equal distribution. And then it also facilitates, as an organization, your own coordination and cooperation with other actors. So it may be that you want to undertake a response, but actually as an organization, you don't have the capacity required to do that. But working in cooperation with another organization, you may well be able, that may well boost your capacity enough to carry out the response. The reason I've put the Médecins Sans Frontières logo at the bottom of this slide is just to say that Médecins Sans Frontières have excluded themselves from the cluster system. They consider themselves observers of the cluster system, but they won't fully engage with it. One of the reasons for this is because they do not feel that the cluster system works very well, and they don't feel that it is coordinated terribly well, and they feel it slows down organizations' ability to respond to the need. And so they want to respond quicker, and they feel they're able to do that. And so they have chosen to take a back seat and not to be part of the coordination by the cluster, but they are considered observers, so they will attend meetings and listen to what is occurring, and then make decisions as an organization on their own as to where they will respond depending on what the actions of other actors are. Having said that, MSF in the last few years has become increasingly engaged with cooperating with other organizations, and actually we worked very closely with them during the Ebola epidemic, and even though we're 2 very different organizations, actually it was a cooperation that worked very well. So then the next thing that we want to ask is the response that's already in place, either from local services or other international actors, is that response covering the need, or is there a gap which our organization can fill? So it may be that there's a gap in service provision. It may be that the extent of the crisis is so large that the service currently being provided is not adequately addressing the full need of the population, maybe because certain locations are difficult to access or cut off, or maybe just because there are so many people affected that the organizations responding don't have the capacity to meet all of their needs. As we saw at the beginning of the Ebola epidemic, when the disease was spreading very rapidly and we required a lot more assistance than was readily available at the time, it took a very large international response with many actors involved to help bring that, or to help control that epidemic and provide enough treatment facilities and beds to treat the number of patients. Also, where is the gap? So is there a gap in location? It might be that there is adequate provision of services in certain regions. Often we find that the main cities or towns affected have a high number of actors delivering services, but it's the rural, harder to reach areas that are not receiving them, simply because accessing them is more difficult, time consuming, and expensive, and so they have been neglected. So it may be that the service provision is adequate, but it's not reaching all of the areas that it needs to reach. It may be that there's a gap in expertise. So it may be that there is adequate service provision as a whole, but there is a group of the population that is not receiving adequate care. So it might be neonatal care or care of pregnant women if neonatal services have been damaged, if hospitals have been damaged, and so there are no maternity centres for women to develop. It may be that an organisation chooses then to set up a specific facility just for the care of pregnant women and the delivery of obstetric care. It might be that specific surgical expertise is needed in certain trauma situations, or where chemical weapons have been used and there are significant burns to the population. It might be that actually the best way of addressing a need is a management of severe acute malnutrition in the child population of the area, alongside providing food support to that area. Or it might be that infectious disease expertise is needed in certain epidemic situations, and these areas may not be covered, and it might be that as an intervention, your intervention is just a very specific niche area rather than a large general intervention. And also it might cover prevention strategies. So it may be that there has been a large disaster and many actors are already responding and meeting the needs of that population, but actually several months in, a measles outbreak develops, and there isn't the capacity within the organisations already present to develop a measles vaccination campaign, and it might be partnering with the WHO to help deliver that campaign. So that takes me on to what form could the response take? Well, there's so many different forms that it could take, and I think often people might rush in thinking that they have to do a full field hospital or something, and that would be beyond their capacity, when actually they can meet a niche area, as I just mentioned, or there are just many different areas that they could be involved in that would still be supporting the needs of that population. So it may be that a full field hospital is required, and the two bottom pictures that you can see there are the Samaritans Purse Field Hospital in action in Ecuador following the earthquake there. But it might be also that actually what we want to dispatch is mobile medical teams. So we want to send small groups who can go and reach rural areas who've been cut off to medical treatment, just with a very good standard medical equipment set, and not providing sophisticated surgery, but meeting the needs of chronic medical problems and minor infectious diseases and so on. It might be simply first aid and emergency support on the beaches of Lesbos, providing that to people coming off boats with hypothermia and minor trauma or wounds and so on. Or it might be epidemic case management, which might be in the context of just an epidemic, or it might be off the back of a disaster situation, like we saw with the earthquake in Haiti, which was shortly followed about 9 months later by the cholera epidemic. Or it might be, as I mentioned, vaccination campaigns, nutritional support, and at the bottom I've put support to a local hospital. That's a very difficult one, because you need to establish your parameters at the beginning as to what your response is going to look like, how you're going to support them, and how you will define when you're no longer needed. And that understanding needs to be in place from that local hospital, because it may be that they feel you should be remaining to support them in the long term, when your intention is purely for emergency response and that immediate disaster period. So that's a very difficult one to engage with, and needs to be, there needs to be extensive discussions in place and a good strategy in place to support that local hospital, but also understanding of when you are going to withdraw your intervention. So what is our end game? As I said before, we should never start an intervention without knowing at what point it will be time to consider terminating that intervention. So we need to have specific criteria in place that say to us, when these criteria are met, our intervention will no longer be needed, or that will be the time to start the process of removing our intervention, ensuring local capacity is in place. So there are different areas that we'd want to consider, and that will again depend on the circumstances that we're addressing, but it particularly comes down to what the local circumstances and capacity are. So if there were already good local capacity prior to a disaster, and it's just a matter of helping them find their feet again during the first couple of months post-disaster, then we might well know very clearly when that might be. But if we're entering a country that never really had a very good local capacity in the first place, it may well be that we have to help develop a degree of capacity before we can remove our intervention. And that has to factor in our decision of whether we can respond or not, because that financially and logistically may be very difficult. If we're looking at responding to an epidemic, then maybe it's more straightforward when we're going to remove our intervention is when that epidemic is contained. But if we're looking at the West African Ebola epidemic, we have to remember that the facilities in all three affected countries was not very good to begin with. And so even though we might be withdrawing our staff running a treatment facility, we may need to consider training or support to the local healthcare workers for a period of time post-epidemic to ensure that they have capacity to deal with any interim cases that may occur, or if there was the occasional further case. So as I put, also services functioning again post-disaster. So once local services are up again after a disaster, it may be that it's no longer appropriate for our intervention to continue. It may be that there's been the end of a conflict and a stable government is now in place and they have re-established the functioning of essential services. Or it might be the resolution of obstruction to basic healthcare and food supply. So it might be the removal of a terrorist group that's cut off an area of the country, and now supplies can reach that country again. Local healthcare workers are able to return to their jobs, and there is a consistent food supply coming back into the region. So all of these are things that we may want to consider depending on the circumstances that we're addressing, and we want to define exactly what criteria will need to be met for our intervention to no longer be required before we even start that intervention. So I've put a slide here which might be slightly controversial, but I think it's always good for us to consider when our intervention might actually not be needed. And that's okay. I think sometimes as international organizations, we're often very keen to respond to circumstances where we feel there's a need, but sometimes we need to recognize that actually the intervention is not needed by the local population, and therefore we would simply be spending a lot of money and time and effort for something that's not required. And so I've put down here a list of points. So the first one, which I think is fairly obvious, is if the intervention is not needed, then we don't need to intervene. If there's sufficient local capacity in the country to provide for that need, that's a far more sustainable way of providing for the need than flying in a field hospital, for instance, and trying to run a field hospital when there's already local capacity with operating theatres and so on. My third comment is slightly facetious, but when it says when there are so many actors trying to meet the need, it is no longer clear what the need is. And that's off the back of several responses where often there are many actors almost falling over themselves to provide a response, and to the point where it can become distracting as to what the actual need is. And I'll talk a little bit more about that when I talk about the European refugee situation. But then there's also when the organisation does not have the capacity to meet the need. So there's no point in intervening if 2 weeks into our intervention we suddenly realise we don't have the finances to continue this intervention. We're going to have to pull it out. And if that is the case, if we can partner with another organisation to ensure we do have that capacity, then that's great. But if there is none, then we need to have thought about that before we intervene. And if we don't have the capacity to maintain a response until the end criteria met, again, that's potentially doing more harm than good in the circumstances, and we need to consider that as well. So I think that just leads me to talk a little bit about the European refugee crisis. So this was a very complicated situation in that it had many different components to it, from people getting on very unsafe boats and the risk of them drowning in the Mediterranean Sea, to them arriving on very small islands of Greece, which are normally don't have a very large population in and of themselves, and are normally tourist hotspots, not areas that 3,000 or 4,000 people arrive in each day. Some of those islands also, just to clarify, do not have a natural water source. So on some of the smaller islands, the Greek government ship water in on a daily basis. Now, if your island only has a population of 200 people, that's fine. If it suddenly has an increase in the population size of 2,000 to 3,000 people every day, that puts a significant burden on the water supply. So initially, we've got people coming in on boats, some of whom have drowned, many of whom are quite traumatized, some of whom are hypothermic because they were leaving the coast of Turkey at 3 o'clock in the morning so that they did not get caught, or the smugglers didn't get caught, pushing them off the boat, pushing them off the side of the beach. And then arriving sometimes within a couple of hours, which is what it should have taken, but sometimes the motors on the boats broke and the boats were adrift for many hours in the middle of the ocean. They were often filling with water, so people were very wet when they got off. So we've got people who are hypothermic, who may have ongoing medical conditions that have been taxed by this situation. So we had diabetics who had lost their insulin and so on. And then we've also got minor trauma and first aid situations from people coming off the boats or banging themselves on rocks and so on. We then have a population who are moving through many European countries. And the next slide shows what was happening in Macedonia. So the population are then traveling from the islands by ferry overnight to get to Athens. They're then traveling several days north from Athens up to the northern border with Macedonia, where they're crossing across into Macedonia. And at that time in Macedonia, in Gevgelia, we were seeing between 7,000 and 10,000 people crossing the border each day. And obviously a population with different needs to those coming off the boats, but also similar. So maybe basic first aid, maybe infections that have cropped up. As you can see there, the lady in the left-hand side of the page holding a little baby. That baby is 3 days old. That picture was taken in Tabernosse on the northern border of Macedonia. And that woman had simply delivered in a health center in one of the islands of Greece and discharged herself almost straight away and carried on walking. And 3 days later was at the northern border with Macedonia. But at this point, the needs of the population are different because they're often traveling overnight. There were not many transit centres at this time for them to stay in, and it was getting cold. This was September. We were coming into October, and at night it was very cold, but in the day it was very hot. So there's a need for blankets and basic supplies for this population, but then also the ongoing medical problems that can occur from not having access to those things and not having access to very good nutrition either. And then we get to a point where suddenly, and this is the next slide, suddenly the borders are closed and people can't move. So the top left-hand picture is actually a picture of Idomeni in Greece. So that's northern Greece on the border with Macedonia, and Macedonia has closed its borders. So the pictures you saw before were people crossing over into Gevgelia in Macedonia. And now we have a camp situation developing because the border is closed and they can no longer cross over into Macedonia to continue their journey. And so we have a makeshift camp situation that's developed whereby the population have set up their own tents, and you can see that it's quite dirty. There's a lot of water and mud. It's probably not very warm. There's no trash disposal, no waste disposal. There's no latrines, and there's no necessarily clean running water. That situation fortunately changed quite quickly, and camps were developed, but people often didn't want to go to the camps because they were further away from the border, and they wanted to be right by the border in case they opened the borders to allow a certain number of people through. So we've got three very different circumstances there and a very changing situation throughout. But we also have a nation that has the capacity, at least the local capacity in terms of having healthcare facilities, healthcare workers and treatments. It might just need support because of the increased number of people. But actually the medical interventions that were generally being provided were basic first aid and treatment of minor infections and so on. And anything more serious was then being sent to the hospitals for treatment. And actually, as Samaritans Purse, we decided not to respond with a medical intervention at that time. We responded in many other ways with shelter and supporting all of the transit centres on behalf of UNHCR in Greece, and providing non-food items and food support and so on. But we did not provide a medical intervention because the local capacity was good. there were already several other actors providing first aid, and it felt like we would simply be duplicating a response that wasn't needed at that time. So we opted in that circumstance not to send our medical disaster response team. And really, that's now the end of my presentation, but I wanted to answer any questions that you might have.
Yeah, if you would please post your questions in the slide box, that would be great for Dr. Natalie. She has a lot of experience, and if you have comments or questions to make on that, we would love to hear them. While we wait for you to do that, I just want to let you know, if you don't already, that Samaritans Purse is deploying their field hospital in northern Iraq come the end of the month here, and we would love to have you consider volunteering for that. So I think with your presentation, Natalie, this is very apropos that we are looking for volunteers, and it very much fits in with Samaritans Purse deciding to respond here. And so if you will go to our website, and go to SamaritansPurse.org/DART. You can sign up to be a volunteer and be considered for that. So just a little plug in for that you would consider that. So please post your questions. I have just a comment, Natalie, as I was listening to you speak, and just kind of the critical piece, and it seems like the whole presentation is that we would do really good assessments, whether that be an assessment for, what the need is, who the players are, how to respond. It seems like if that piece is done well, the rest of the things kind of fall into place. But if you fail at that part, or you don't do as good of assessment, there's problems with the response.
Yeah, I think that's right. If you've got a robust assessment situation in place, you know who your target population are, you know what your response is going to look like, and you know what capacity your organization has to respond. And then your response, well, it's not necessarily going to be straightforward, and it's not necessarily going to be without problems, but at least you know what you're trying to target, and you're linked in with the local services that are there, you're linked into the cluster system and coordination, and you know when you're going to remove your intervention at the end. Then I think you at least have a plan in place. That's not to say the circumstances might change and your intervention might need to continue going for longer, or it might need to change its remit because of the circumstances, but at least you're continually assessing the situation as well, so you know what your plan is.
Yeah, very good. We do have a comment here, question from Martha, and she said she would be interested in hearing what you understand to be SP's unique contribution to CHW. What are the best in terms of clinical / medical response, and what could be strengthened?
CHW, can you?
Well, you know what? I'm going to have to ask Martha what CHW stands for, because I myself do not know. So Martha, we'll let you respond to that, if you could clarify that, and then maybe Skip Roy, if you could respond to this. In the case of an unanticipated disaster, is it the UN or the WHO or the local Ministry of Health that coordinates the response?
So that depends on the capacity of the local Ministry of Health. So if it's a country that has an adequately functioning Ministry of Health, and that hasn't been affected by the disaster, and they want to take the lead, then it is the Ministry of Health of that country. If the country is, for instance, like South Sudan, where there is not a very robust Ministry of Health, then it is likely that the United Nations alongside the WHO will take on the cluster system, and they will lead the clusters. And so the WHO in that circumstance would lead the health cluster. And if it's a country that had a robust Ministry of Health in place, but the circumstances mean that it has the disaster has affected the functioning of that Ministry of Health very significantly, then it might be that that local government invites the UN in and asks the WHO to lead the cluster instead, because they don't have the capacity at that point in time.
Okay, great, thank you. And Martha has clarified her question to mean, I'll just read it again for us. she'd be interested in hearing what you understand to be SP's unique contribution to complex humanitarian emergency. What's the best in terms of clinical medical response and what could be strengthened? So maybe just give us your experience with that.
Yeah, so I guess in terms of complex humanitarian emergencies, that was focusing quite heavily on nations affected by conflict. So where we've been involved in conflict zones, particularly most recently, we've been involved in South Sudan with a large response prior to South Sudan even becoming independent and then following independence. And then there has been ongoing conflict in South Sudan following that. Not necessarily in a big healthcare way, but we have supported, there has been support to local health facilities and there has been health interventions. I guess Iraq is now becoming one of our big responses, and in that case we are now dispatching our field hospital, and that's in association with the World Health Organization. They've invited us to do that, so it's in partnership with them, and that's to respond to the ongoing trauma needs of that population. So as IS are pulling out or being forced out of Mosul, they're leaving behind many IEDs. There's also a conflict situation, so we can expect significant trauma, and we can expect significant trauma when people return to their homes or their regions, because there are so many IEDs around that actually some of them are going off as people return home. So that hospital is to respond to that trauma, but we're also responding with mobile medical teams there at the moment, even prior to this hospital being dispatched, to provide for the basic healthcare needs of a population who haven't had really any access to healthcare now since IS have been in Mosul, which has been, I think, about 1 to 2 years, a couple of years maybe.
Mm-hmm. Very good. We have one more question from Skip, and he said, having heard about SP's response in Iraq, where does the security of folks who intervene come into play, and who makes that decision about when the intervention is in a relatively safe place? I can speak a little bit to that, but I'm sure you can speak a lot to it as well, having been on the ground.
Yeah, Samaritans Purse has very, very robust security systems in place, and they would never intervene if they felt that there was no way that they could support and protect the staff that they were sending in country. So I know that the ongoing situation in Mosul is still quite dangerous, but because of that situation, there's actually a lot of international support, for security support in country from other organizations, including the UN and military organizations, but also SP is very heavily involved in supporting the team out there and training people prior to going out on how to respond in certain situations. So SP would never respond to a situation if they felt that there was no way they could look after their staff. But there is always going to be some element of risk in going to a situation like that, and you can't eliminate that risk because of the circumstances that are there. And so to some degree, it is a personal choice in whether you respond, and you respond knowing that there is a degree of risk involved.
Yeah. That's great, Natalie. I think you answered that question really well. We have a whole security department here at Samaritans Purse that's intricately involved in decisions that are made like that, and ensuring safety of our staff and volunteers, or like you said, doing the best you can. There's always risk when you go out, and some places are higher risk than others, of course. So with that being said, I guess there's one more question here from Chris, and he said, with SP being a Christian organization, can you share how deploying with a faith-based organization might be unique from others?
Yeah, I think it is quite different than responding perhaps to this more secular organization. I think, first of all, we go believing we're going because Jesus wants us there, and we're going to be the hands and feet of Jesus and meet the needs of a population, and irrelevant of their race, religion, creed, irrelevant. We will respond to a population who are in need, but we go with prayer. We go believing that it's where God wants us, and that being in God's will is the best place in the world to be. And we're also covered by prayer by the SP International Head Office in Boone, but also by the affiliate offices in the UK and Australia and Canada. And there's people constantly praying for us when we're overseas. And I think it also changes how we respond to things. some aid organizations sometimes perhaps get a bad reputation for drinking large amounts of alcohol, smoking a lot, and so on, just because that's one way people deal with stressful situations. But I think when you go as a Christian and you go as part of a faith-based organization, you have other ways of dealing with those things, which is working with other people. It's praying, and it's praying together to help you to deal with the situations that you face. And I think that comes across a lot, certainly to other organizations we work with, in terms of our integrity of how we go about our response. And obviously we also, where it's possible, we would like to witness to people that we're with. So we don't just bring physical medical healing, but we come with spiritual healing as well. And we also want to share the good news of Christ with people. That's not always possible under the circumstances. So in certain camp situations, that might be precluded by the people running the camp or so on. But wherever it's possible, we do, and we are free to pray for people if people would like us to pray for them as well. So it brings a whole new element to our ability to respond.
Great. Well, thank you so much for sharing with us today, Dr. Natalie. We certainly have learned a lot and appreciate your presentation and taking time to share your experiences and just, yeah, learn from you today. So thank you for all those that participated today. I want to remind you all that CME is available for this talk. If you are a doctor or a nurse and you would like to receive that, it is through Orlando Health. So if you check the email, you will find you can download the evaluation form that you will have to send in, and then you will have to send your attendance to us, but please send your evaluation form directly to Orlando Health, and that is all outlined in the email. So if you just can read and follow directions, you can get the CME for that. I'd like to invite you too for next month, starting the new year. We will be meeting again January 11th at 12 noon Eastern Standard Time. We have SP's own Julie Tanaka, our Senior International Nutritional Technical Advisor, sharing with us, and she is going to be talking about the battle for breastfeeding in limited resource settings, what every clinician needs to know. So I do hope you will be a part of that discussion in January, and we wish you all a blessed Christmas.